Welcome to Talking Meds on the PrescQIPP podcast, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill. Hello, my name is Jonathan Underhill. Welcome to the latest edition of Talking Meds. I'm delighted to be joined today, not by one guest, but by two very special guests. We've got Stephanie Bancroft and we've got Dr. Janine Barnes. And we're going to talk about Parkinson's disease and some of the issues and challenges around use of medicines and other things actually around Parkinson's disease. And one of the reasons we want to talk about this on this podcast is that PrescQIPP are hosting a series of webinars on Parkinson's disease. The first one starts on the 9th of October, so you've still got time to register for that. We're going to do a series of 4, and the one after that will be on the 20th of November, and then we're going to do some more in December and January as well. So this is by means of whetting your appetite to what the potential issues are around the management of Parkinson's disease. So firstly, to come to Stephanie. So Stephanie Bancroft has a background as a community pharmacist, and she's now chair of the Parkinson's Disease Specialist Pharmacy Network. We'll put a link to that in the show notes so that you can go and join that if you're so interested. She was the lead for the Parkinson's Disease Specific Medicines Use Project, which was trialled in 8 pharmacies in Northwest London and then was done nationally to great acclaim and success as well. She's managed various community pharmacy projects on various topics, including COPD, glaucoma, asthma, but it's Parkinson's disease that is Stephanie's big area of interest. I'm delighted to be joined as well by Dr. Janine Barnes. I've known Janine for quite a while now. Janine sat on the guideline development group for the Parkinson's disease guideline that NICE did when I was working at NICE, and I also worked with Janine on MTRAC from Keele University. As far as I'm concerned, she's one of the leading pharmacists around Parkinson's disease and neuropharmacology. And so delighted to have both her and Stephanie here today. So Janine did her PhD in neuropharmacology, then became a researcher and a clinical lecturer, was one of the first cohorts of independent prescribers back in 2007. Apologies if that gives your age away, Janine. And you were the first accredited pharmacist with a special interest in neurology as well, and was awarded the RPS prestigious Clinical Pharmacist of the Year in 2012. We're here, as I said, to talk about Parkinson's disease. We're here to talk about, in particular, the wonderful Parkinson's Disease Specialist Pharmacy Network. Janine's the deputy chair of that now, and Stephanie is the chair. So, welcome to the podcast. I guess just to start with you, Stephanie, was there anything that I missed there that you'd like to highlight to listeners?
No, I think you got everything. I mean, my passion for Parkinson's started in a very personal way for me. My mother was diagnosed with Parkinson's, and as a pharmacist, I soon realized that I really didn't know enough about Parkinson's to be able to support her. Although she was a pharmacist herself, she seemed to know a bit more than me, and I thought, no, this can't be right. So I took it upon myself to learn more, and I was in a fortunate position because in those days the Royal Pharmaceutical Society had a local practice forum, and I was the chair of that, and I could arrange educational meetings, which I did. And the pharma company that supported that meeting wanted to do more. That's what led to the MURs. And I think over the years, my network has increased. And when Janine asked about starting a specialist pharmacy network, I thought it was an absolutely brilliant idea. And she gathered together a group of people, and I was nominated as deputy chair. I never expected to be in the position of chair, but I'm sort of there and trying to do my best for the pharmacists that are interested in Parkinson's disease. And we're going to be holding our 4th conference in June 2026.
Fantastic. Thanks, Stephanie. It's interesting how often a lot of the guests that I speak to about their passions in life or their passions within their profession comes from a personal experience. I've always been interested in Parkinson's disease, and we talked about this, didn't we, Steph, when we had our pre-meet. My dad had Lewy body dementia, which obviously is a sort of it's a dementia, but which is characterized where you have symptoms of Parkinsonism as well. And it's always made me fascinated by how you help people with Parkinson's disease as well. So it's a passion of mine as well. So I'm delighted to have you both here. So Janine, just by means of introduction, I could have talked for hours about your career. Was there anything in particular that I missed from my introduction for you?
No, I don't think you did really, Jonathan, but I was just thinking, going back to what Stephanie said, how it all kind of started. I was at the Clinical Pharmacy Congress probably 4 or 5 years in a row, presenting about Parkinson's disease. And I mean, it was just ridiculous how much interest, it was like full lecture theatre, standing room only, loads of questions after. So clearly there was a really big unmet need for education in Parkinson's disease for pharmacists. So really at that point, I kind of managed to find a group of like-minded pharmacists. We got a constitution together, steering committee, and there we were. We'd formed this network, the Parkinson's Disease Specialist Pharmacy Network, and it kind of just went from there from 2018. And I should just say, obviously I was chair initially, working full time. The amount of work you have to put in is crazy. And Stephanie took over the chair in 2022. And I mean, it's just been amazing what she's done, growing it and all the effort she's put in. And it's been fabulous, really. So thank you, Stephanie.
Thank you, Janine. That's very kind. I just should say that we've got over 400 members of the PDSPN, and it's growing all the time. And we've even got some overseas people from Australia, New Zealand, a couple of other countries.
Fantastic. So specifically then about the Parkinson's Disease Specialist Pharmacy Network, is this open to all pharmacists? Is it particularly for prescribers or community pharmacists? What?
It's open to any pharmacist or pharmacy technician or even any allied healthcare professional who is interested in Parkinson's disease. It's designed to help them to understand Parkinson's better and to help and then obviously that will help them to help their patients.
And I could just add, Stephanie, at the conferences, we've had quite a multidisciplinary audience, haven't we, with physios, speech and language therapists. I think we've had GPs, so it's great, really, that the learning is being cascaded across the professions, isn't it?
Yeah, I mean, that's one of the things that strikes me about Parkinson's disease. I'm a big fan of the Movers and Shakers podcast, and I think it's only right that you, on a podcast, you give a shout out to other really, really good podcasts. So those people who haven't heard of it, Movers and Shakers is a podcast where people have, it's patients with Parkinson's disease, but these patients are a bit different because it's people like Jeremy Paxman and Rory Kethlen-Jones and people like that who are, media personalities, if you like, but talk very candidly about their struggles with Parkinson's disease. And in particular, some of the stuff around medicines and how they struggle with the medicines in Parkinson's disease. But as you also say, it's that multidisciplinary team that's really important, the speech and language, nutrition, your generalist, as well as your relationship with your specialist as well. All of these things need to come together, don't they?
I've actually been on one of the Movers and Shakers podcasts, helping them with their medicine issues. And at our last conference, we invited Rory Kethlen-Jones and we did an on-the-couch interview, which was very enlightening.
Yes, I mean, he's also spoken on the Oral Apothecary podcast as well. So some of my colleagues, friends have that, and he was a fantastic guest on there. Just as I said, talking very candidly about his struggles and his relationship with his medicines. Actually, it's fascinating. So on that theme, then, I remember the movie Awakenings, which talks about how they first used levodopa in people with movement disorders, and it's almost that sort of, there was nothing before that for treatment of Parkinson's disease. I guess things have moved on since we first started using things like levodopa. But what are the big challenges around medicine's use in Parkinson's disease for pharmacy teams? Who wants to take that one? Go on, Janine.
Okay. Well, I think the thing with Parkinson's disease, the patients are on usually very complex medication regimes, so it fits perfectly with pharmacists, you know, the experts in medication really. We mentioned the importance of understanding levodopa, which is a time-critical medication, ideally avoiding food, 5-hourly intervals, so that's really important. I just thinking of a few things that, you know, we talk a lot to really about pharmacists is sort of the importance as well of not switching brands, because that's become very apparent with some work we've done at the PDSPN, that patients really, really struggle when the brand of medication is switched. And I think probably the biggest issue is the side effects of the dopaminergic medication. So I can't think of a dopaminergic drug that doesn't cause, in high doses, hallucinations, postural hypotension, all these sort of issues. With the dopamine agonists, so you've got the oral ones, the pramipexole, ropinirole, the rotigotine patch. What you've got to really watch, and I'm sure most people have heard, are the hallucinations and obsessive behaviours, you know, the impulse control disorders really. So I think it's really important, and certainly that came out in NICE, when you're prescribing or dispensing, you need to document really that you've had that conversation with patients about these potential side effects, and also to the carers and people around them, you know, so alerting them to the complexity really of the medications, I think, is a big one.
Yeah, and I think in community pharmacy, there are other issues as well around timing of medication. It's been, well, we've discovered that the consultants who prescribe specifically time the medications for the patient, and the letter goes to the GP, but then those timings do not get transferred to the prescription. The patient can't remember what the timings were, and the pharmacist doesn't know. The prescription says, as directed by your consultant. So we are hoping to do some work on how we can make sure that everyone is on board and understands that if the timings are written on the letter from the consultant or the prescriber, then those timings need to be transferred onto the notes and onto the prescription. And also, if it helps the patient, the pharmacist can prepare multi-dose systems. But multi-dose systems only contain 4 slots. Patients are on possibly 8 times a day medication, including their other medication that they have to take. So I used to do, I had a couple of Parkinson's patients, and I used to do 1 dosette box for the morning doses and a second one for the afternoon doses, so that they could have up to 8 timings. I think that's the biggest issue, is timing, isn't it, Janine?
Yeah, I'd agree, Stephanie. And interestingly, I tried to do that recently to get a patient who had 5 or 6 doses, and it was impossible getting a community pharmacist to agree to do 2 dosette boxes, which is, you know, a shame really, isn't it? But I was just going to say, with the timing, what we try and do is more do dose interval rather than give them specific times, because it just seems wrong that patients are perhaps setting alarms, you know, to wake up. So we feel like the medication's got to work for them rather than the other way. So I try and say 5-hourly intervals from whenever you wake. You know, patients who are working might wake up later at the weekend, you know, and kind of fit it into the life system, you know, and the schedule really.
I think also that patients understand when they're starting to go off.
Yeah.
When the medication is stopping, is not working as well. And if that's the case, then they can take their medication when they need it, and then report that back to whoever is the prescriber to say that it's not working for as long as it was.
Yeah, I think it's a general rule, it's 5-hourly. You shouldn't be going longer than that, you know, with the half-life. So yeah, and within that, they work it to their quality of life, I suppose, don't they?
Yeah, or if they're going out somewhere.
So it's very much the patient being in control as much as possible of what they're doing and knowing what's right for them. So I guess the message is for healthcare professionals, make sure you talk to your patients to find out exactly what's going on and how they're getting on with their medicines. And as you say, you know, that on-off effect that you get, the end of dose effects that you get with traditional Parkinson's medicines. Again, there's no large studies that have described a pattern there. It's very much individualized, isn't it? For some people, it can be not a problem, or can happen at a certain time period, but and for others, a different time period. So it has to be an individualized thing. I remember when we did the NICE guideline, Janine, again, it was one of the earlier ones that we did, but it was very much, this needs to be an individualized approach here. There's no randomized controlled trials telling you how to manage a person with Parkinson's disease on a, if you like, by rote or by guideline. It's much more about the principles and talking to the person, finding out what matters to them, finding out how it's working for them, finding out how they're getting on, how they're tolerating the medicines, how they're getting on with the side effects.
And the wearing off manifests differently as well, you know, so you can't, some people it's tremulous, some people it's slowing down, you know, it's so bespoke, really. It's important, that, isn't it?
Indeed. So for me, but when I was taught about the pharmacology of Parkinson's disease way back at Sunderland in 1986, 87, 88, I was fascinated by the pharmacology of this because it is one of those fascinating things. But I remember seeing my first few patients with Parkinson's disease and talking to them, and it wasn't as it was described in the pharmacology lecture. It was very, very different to that. It's a great example, I think, of the theory being all very interesting, and you get very passionate about it as a pharmacist, but the practicalities are very different. So I guess it's like, how do people get up to speed with this? How do you develop your skills? How do you upskill to learn about some of the challenges around medicines use in Parkinson's disease? Stephanie, do you want to take that one?
Okay, so the Parkinson's Specialist Pharmacy Network have worked with Parkinson's UK to develop a learning pathway which is open to all healthcare professionals. It's a course where you learn about the medicines, you see people with Parkinson's, they talk about their symptoms, you learn about time critical, etc. It's supposed to take 10 hours. However, if you've got some knowledge of Parkinson's, it will take a lot less. I think the 10 hours includes a lot of background reading as well. So that's one way. And anybody, it's free, and anybody can log on to Parkinson's UK professional platform and do that course in their own time. And I think you don't have to do it all at once. Then we're doing the 4 webinars, so that should help people to understand more about Parkinson's and perhaps encourage them to learn a bit more or to delve deeper. The thing that worries me the most is that there are 2 services that the NHS run. One is the discharge medicine service, which is mandatory in community pharmacy, and patients who have Parkinson's and have their medication changed whilst they're in hospital, if they've been admitted, it's compulsory for the pharmacist to give them advice and make sure that those changes are followed through. And there's the new medicine service, which is for anybody newly diagnosed with Parkinson's. My worry is that if the new medicine service is not mandatory, so there's a couple of worries there. The main worry is that if a community pharmacist is not up to speed on Parkinson's, will they give the right advice? Will they give any advice at all? The new medicine service is not mandatory. They may say, well, I don't know anything about Parkinson's, so I won't bother with this. I'll just do dispense the medication and give it out. But I think we're failing if we're not helping patients. We are the most approachable of healthcare professionals. You don't need an appointment to see a community pharmacist, and we're supposed to be experts on medicines. So if we can't help the patient, then who is going to help the patient? They only get appointments with their specialist every year, or I've heard 18 months. There aren't enough Parkinson's nurses, so not every patient has got a Parkinson's nurse. Why aren't there Parkinson's pharmacists? We could have one in every primary care network that could handle local issues with patients. They could be referred by the community pharmacist to that pharmacist if there's a problem, or the GPs can refer them, because GPs don't know enough about Parkinson's, can't change medicines. I think we need to just be more confident in helping people with Parkinson's.
Yeah, I think that I completely see where you're coming from there. Interestingly, in the 10-year plan, there's lots and lots of talk about enabling community pharmacies to deliver services in the future, isn't there? And for me, Parkinson's disease seems like one of those services that would work really well. As you say, the accessibility of community pharmacies is the greatest in all of the NHS. You can, as you say, you don't need an appointment. It's one of our great strengths, I think, that they're in the communities where people live and work and socialize. So, but as you also say, we need to make sure that community pharmacists are upskilled in order to be able to help meet the challenges around medication use in Parkinson's disease. So, I mean, it sounds like these courses and things like the network is something that can really, really help with that. Janine, for you, what are the big challenges for medicines and pharmacy teams here?
I think I think the upskilling is really, really important. And I think there's a lot of confusion with the time critical Parkinson's meds and the gap between food, because with levodopa there's an absorption problem with protein, so if it's taken too close to food, that can be an issue. And I think it caused a lot of confusion on NICE as well, if you remember.
I do remember.
We all went off in a huddle. Parkinson's UK, I think their advice is take medication 30 minutes before meals. You hear various things. Some people say an hour after, an hour before. But really, I think the evidence was that it's quite a small group of people it affects, really, that problem. So NICE's view and advice was the protein redistribution. So not limiting your daily protein intake, but maybe having your main protein load later in the day, your main meal later in the evening, which I think when most of the medication's been taken, and I think that's true pretty much in the Midlands and the South, but certainly from where I come from, your main meal is your lunch time. So there's a bit of re-education needed there, really, as much as anything, to say push the ball further.
Yeah, you're right. So in NG 71, that's the Parkinson's disease guideline. The recommendations on nutrition 1.7, 1.711, 1.712 talks about daily protein intake and when do you do that. And I think you're right. I think for most people, it's not uncomfortable to have most of your protein intake as your final meal of the day. But that might not fit everybody's lifestyle. And again, it's about tailoring that to the individual to find out what works best for them. I think the other thing to say is where in the north we have breakfast, dinner, and tea.
Yeah.
We don't have lunch in the north.
No, but when you say dinner, that would be lunch to me, but to my Midland friends, it's evening meal. So straight away you've got issues.
Exactly.
Yeah.
Exactly. So we've talked about the webinars, we've talked about the network. Just in terms of other things that might be coming around the corner around the management of Parkinson's disease, what's on the horizon here, Janine?
Okay, so I was thinking about this really. I don't see, sadly, a cure on the horizon. The neuroprotectives seem a little bit closer than cures. And disappointingly, really, it's not new drugs, it's kind of new formulations of old drugs coming through. So we've got sublingual apomorphine coming through. So currently it's just an SC injection or a pump. You've got duodopa as an advanced therapy. So that's the levodopa, carbidopa intestinal gel. So obviously it's a continuous infusion using a portable pump via percutaneous jejunostomy. So, major surgery really is the bottom line. But what we've had licensed in the UK since February, I remember the date actually, February the 27th, 2024, was Produodopa. So that's really been a big excitement to the Parkinson's community. So that's foslevodopa, foscarbidopa. So again, administered as a solution as a prodrugs for a 24-hour continuous pump. So that's new in itself to have a 24-hour use, and again for advanced Parkinson's. So because it's a prodrug, it's quicker onset of action. We don't need surgery, and it's a 24-hour pump. So it helps all the motor fluctuations. So it's caused a lot of excitement amongst the Parkinson's community, but they do need to have been considered for apomorphine or deep brain stimulation first, and then that's an option. So certainly locally, we're trying to get that set up because it was passed by NICE, so that's probably the next thing coming in. But like I say, really, it's an improvement on an old drug, isn't it, really?
Yeah.
Still levodopa.
Yeah.
1960s, wasn't it, levodopa?
Yeah, crazy. Yeah, that's disappointing, isn't it, really, that, the gold standard treatment for any motor disability is still a drug from the 60s when you compare that to MS, and epilepsy, where things are coming out all the time. It's quite disappointing, really.
And yet Parkinson's is biggest growing neurological disorder in the world, I think.
So yes, every 20 minutes somebody in the UK is diagnosed with Parkinson's disease. It's crazy, isn't it, really? It's
I don't, they haven't yet discovered what causes it is the biggest problem. They're looking at gut microbiomes, traveling brain.
I think this is the problem as well. There's very little known about it, really, even now. So I did my PhD quite a bit, part of it, all those years ago, and you think, have we moved on that much? We haven't really.
Not really, no. I've been interested since 2014, and there's been very little change in the last 11 years. So,
well, we can live in hope, can't we? That, as you say, this is not something, I'm sure the pharmaceutical companies and other companies are doing lots of research in this area. Because as you say, if somebody does find something that is a major therapeutic advance, given the size of the population, given the aging population, given the size and the number of people being diagnosed with Parkinson's disease on a daily basis, never mind a yearly basis, it certainly makes.
Yeah, I think also there's more young onset Parkinson as well. We're seeing young people, and of course that takes a while to get diagnosed because they're not looking for Parkinson's because it's somebody young.
And the symptoms are very similar to aging, aren't they, really? This is the other problem with the older patients. What's the aging process? What's the Parkinson's? So I think it means people delay really getting a diagnosis often.
Yeah, so I mentioned my father's history. It's it's something I kind of thinking about all the time for myself. 57-year-old, and you can't do the things you used to be able to do when you were 27. And I'm thinking, am I just getting old, or have I got the touch of Parkinson's coming on here? And I guess what do I do about that? It's quite an interesting one for me personally.
Yeah, well, then they're not 100% sure that it isn't hereditary.
No, I know.
Well, it's quite a small percentage, isn't it? And we always struggle with that. Do you say go and get tested, go and get your children tested when there's no cure? And really, it's symptomatic, isn't it? So you wouldn't have tablets until you needed them anyway. So it's a hard one, isn't
it? Exactly that. If there was something, then maybe I'd do so. I'd actively seek it. But yeah, I'll just manage my old age as best I can, and try and keep cycling and playing cricket, etc. As long as I can. So just in terms of just to finish off, then we'd like to come up with kind of your 3 take-home messages for pharmacy teams or clinicians. So I don't know. Do you want to give me one each, and then one of you have another one, or what? How do you want to do this?
Yeah, I think we can give one each.
Go on then, Janine. You start.
Okay, I would say probably my overriding one would be multidisciplinary team working. I think from NICE they said that everybody newly diagnosed should be referred early on to the following professions that are all trained in Parkinson's disease, so not general therapists, but Parkinson's trained, and that was nurses, physio, OT, speech and language therapist, and dietitian. Again, very disappointing they didn't mention pharmacy, but yeah, that's that seems to be the way things tended to be at the moment. But I think pharmacy is such an important profession, as I've said, with the medication. And we also involve psychologists as well in our multidisciplinary team because of the non-motor symptoms, the anxiety, potential depression. But I think really the message is no one profession can provide everything for a person with Parkinson's disease. So we really do need to work together as an MD team, multidisciplinary team.
Yeah, completely agree with that. That's really good. Stephanie?
Well, I think that pharmacists shouldn't be shy of learning more about Parkinson's. We should be able to talk to our patients, find out what's bothering them, understand the medicines that they're taking, give them appropriate advice. And as we see them the most often, the patient should be able to turn to us for that support, because it's frightening out there. If you've got a diagnosis of Parkinson's, what do you do? Who do you talk to? And if you can go to your local pharmacy and talk to your pharmacist, that sometimes is a very reassuring aspect of living with Parkinson's.
Yeah, I completely agree. There's almost a carrying call there, isn't there, for saying, right, the 10-year plan's coming out. Community pharmacy is going to be front and centre of that in terms of neighbourhood teams, etc. Here's an opportunity. If you upskill in your knowledge of Parkinson's disease, you can really help people here. You can be part of this multidisciplinary team that can really, really make a difference. So no, I really like that. Who wants to give us one more just to finish off?
I was going to say time critical. Are you going to say the same?
Yeah, pretty much. I was going to say time critical, but also the fact that we did a local audit to our Parkinson's community and said, what's the one thing that you need most help with? And they said medication. So that's where most confusion is, and that's where pharmacists can come in as the most powerful cohort, really, to help them.
Yeah, I mentioned the Movers and Shakers podcast earlier. I think every other episode they're talking about medicines within that. So it's clearly a really, really important thing. And who are the experts on medicines? It's us pharmacists and pharmacy technicians, isn't it? So yes, carpe diem here, eh? Okay, thank you so much for your time, Stephanie and Janine. It's been a fascinating conversation. As I said, we're going to be doing a series of webinars on this. We'll put the links in the show notes to the network and some of the other the learning pathway that you mentioned, Stephanie. Thank you so much. Hopefully people found that really interesting, and hopefully see some of you on the webinar. Cheers, guys.
Thank you.
Thank you very much.
Bye.